learning more and more every day. So good morning or afternoon to everyone here. My name is Courtney Johnson. I'm a clinical associate and postdoctoral research fellow with the Department of Dermatology at Johns Hopkins. And so today my talk will follow the outline as listed here. I'll give an overview of cutaneous T-cell lymphomas. I'll talk about some of our clinical assessment tools that we use and how we go about diagnosing patients with this disease. I'll also talk a little bit about the epidemiology of this disease, some disparities that we're aware of in this population, as well as how different comorbidities may affect this patient population. And then finally, I'll end talking a little bit more about the biology of the cutaneous T-cell lymphoma disease, and then some future technologies that we're using to better understand this disease. So to get started, the World Health Organization defines over a dozen different types of primary cutaneous T-cell lymphomas. Now, these disorders are a heterogeneous group of non-Hodgkin lymphoproliferative skin-homing malignant T-cells. And for the sake of today's presentation, I'll really focus on the two most common types, which is Mycosis Fungoides and Sézary syndrome, which account for about 50 to 55% of all CTCLs. So Mycosis Fungoides is a low-level lymphoma with a really indolent clinical course. So for most patients, this is a disease that they will manage for the majority of their lifetime. When patients do present, they come in with patches, erythematous patches or plaques, but if they have a more advanced disease, they can have tumors and extracutaneous findings, including the areas of the lymph node, blood, and visceral organs as well. Sézary syndrome is a bit of a different form, so it's more of the leukemic variant of this disease. And so it's defined by a triad of three things. So there's the pruritic erythroderma, there's the generalized lymphadenopathy, and then there's the clonal-related neoplastic T cells. And this disease is much more aggressive in comparison to Mycosis fungoides. And it typically does progress to systemic involvement and has an overall poor prognosis. So it's important to note that Mycosis fungoides comes in a variety of variants. And so as you can see, this list is pretty extensive. And I tell a lot of the residents here that it should never be too far away from your differential diagnosis list. Because of these variants, patients can present with various findings. So as the patient in the left upper photo has this more poikilodermatous, hyperpigmented patches and plaques, or they may have more hypopigmented plaques as seen in the image here on the left lower hand side. They may present with nodules and plaques that may erode and ulcerate. And patients with more advanced Mycosis fungoides or Sézary syndrome may present with indurated erythematous plaques or even subcutaneous nodules, or complete erythroderma, which is about 80 to 90% of body surface area involvement, as seen in the photo to the far right. Clinical and pathological correlation is really important when you're trying to make the diagnosis of Mycosis fungoides. So to do so, we conduct a thorough investigation of the skin, the lymph node, the viscera, and the blood. So we do this through a thorough history detailing the patient's disease course, their prior treatments. We also do a complete physical exam of the skin. So we look at the lymph node, we do a lymph node assessment, palpation for masses, organomegaly, or any other masses. And then we also use an SWAT sometimes to help us assess the amount of involvement of the skin. And I'll talk a little bit more about that in the next slide. So at minimum, we take 2 biopsies, or at least 1 biopsy from all morphologically different areas for a histological assessment. And this is really important because Mycosis fungoides can be difficult to assess, and so more biological samples may help with that diagnosis. Other blood tests are listed here. Molecular studies will go into use, and then additional biopsies may be necessary of different compartments as well. So as the SWAT I mentioned before, it's a tool that's used in clinical trials to determine the body surface area by a factor that's really dependent on the location and clinical morphology. So when we use the body surface area alone, it may not always reflect the severity of Mycosis fungoides. So for instance, a patient who has a few tumors may have a more inferior prognosis as compared to a patient with patches and plaques that take up a similar body surface area. So this tool is really great, especially to incorporate in your initial visit, because it can help to monitor the response of a patient over time. On histology, there's classic findings of this band-like infiltrate of atypical lymphoid cells with these cribriform nuclei in the superficial dermis. And then they may form these intraepidermal microabscesses, also known as Patriae microabscesses in the epidermis. And then by immunohistochemistry staining, we can start to see that there's a predominance of T cell type CD4 as compared to the CD8 T cells. And then, unfortunately, using just histology alone is not enough to make the diagnosis. In fact, it's a 40% false negative rate and a 44% false positive rate. So you really do have to tie everything together with the clinical and the histology to make this diagnosis. Now, flow cytometry is a helpful ancillary study that we can also use in the initial diagnosis of this disease. It helps us really evaluate those different T cell populations. So we can use antibody stains as listed here to identify those T cells that are atypical. And we look at it in two ways, either the quantitatively abnormal cells versus the phenotypically abnormal cells. And then also we can use the TCR receptor to also identify these clonal populations. So I think majority of places now use mostly PCR to determine their clonality of that T cell, to look for that population of clonal cells in the blood or tissue or the lymph node or the bone marrow. But newer technologies are moving towards using, or places are using newer technologies such as high throughput TCR sequencing or next generation sequencing as a more sensitive and more accurate method for clonal detection and monitoring as well. So I put this slide here just to kind of give a simplistic overview of how clonality with a PCR detection versus sequencing detection compares. And so really the summation of this slide is that by PCR electrophoresis, we are really just looking at detection of tumor clonality, like especially on this electrophoresis band. Do we see a band or do we not? But we don't know some more specifics about if that band is, what's in the band, what makes up the different parts of the band. And if the band doesn't show, we still don't know anything more quantitative. So using deep sequencing, we can actually start to quantitate the more dominant clones and actually see more accurately and more in depth, improving our detection overall. And so I really like this figure here from this paper that shows really how clonality can be masked by that electrophoresis, gel electrophoresis and PCR. So in case one, there are sufficient copies of DNA to detect two clonal population. And this really does correlate with what you see in the high throughput sequencing findings. However, if you look at case two, there's not enough clonality or enough population of those cells in order to show a detected band. However, if you quantify it with high throughput sequencing, you can actually quantify that much more accurately, and therefore you can see that there is some clonality. So overall, again, clonality can't be used alone. You still have to use it in the context of clinical and pathological findings in order to really diagnose this disease. Now, moving more into imaging, using PET scans or PET CT, this is a great non-invasive diagnostic tool for really measuring the metabolic activity of the cell. So we use fluorodeoxyglucose, which is a glucose analog, and it's absorbed by various tissues just as normal glucose is. And then we measure that uptake in the skin, the nodes, and the solid organs as well. And so this is really helpful because we can detect deeper lesions. We can accurately measure lesions thickness, which does correlate with some survival outcome, as well as nodal disease of subclinical lymph nodes as well. So all of this information is taken together. An algorithm was proposed by the International Society for Cutaneous Lymphoma to help with this diagnosis, and it gives us more information. And then we can put all these together to make up the clinical, the histopathological, the molecular studies, and our immunopathology pathology as well. And the diagnosis of mycosis fungoides can be made once 4 points or more have been determined. And once a diagnosis of mycosis fungoides disease has been made, it can then be used to identify the stage of the patient, which can then be used to determine survival. So for those who have not seen, this is the T, or the tumor node metastasis blood classification. And here, using that information, we can determine their stage of disease. And so the red line really delineates early from late stage disease. So from 1A to 2A is considered early stage disease. And this is typically just skin involvement. And these patients have a really good prognosis. But 2B and 4B, and including Sézary syndrome, is considered more advanced disease or late stage disease, and they have a worse prognosis. So 71% of patients will present with this early stage disease. Of it, though, about 34% will progress to the more late stage disease. And early stage disease has a median survival of about 13 years, so they live a nice long life, but late stage disease has a median survival of about 4 years, and maybe even less than 13 months if they have lymph node involvement. And so treatment is determined by staging. So I really like this image here because it helps us kind of categorize how to go about treating our patients, depending where they are on this chart. So early stage disease really focuses on skin-directed therapies, including topical steroids, nitrogen mustard, phototherapy, radiotherapy, and others. Whereas more late stage or advanced disease uses a combination of the skin-directed therapies as well as systemic medications, including systemic retinoids or interferon, chemotherapies, antibody therapies, as well as even stem cell transplant. Unfortunately, despite all of this, overall survival for patients with advanced disease really does remain unchanged. Even when we give them these more intense regimens, there's really minimal clinical improvement. And so most of what we do nowadays is really palliative. And so just kind of putting it out there that one of the things that's really important is for us to develop more effective treatments and early diagnostic markers for patients with advanced CTCL. So we're still trying to learn more about this disease. The molecular pathogenesis is still largely unknown. We know a few genetic defects that have some pathologic significance, but we really don't know the specific genetic drivers for most CTCL patients. And to really complicate things matter, there's a wide variation across the spectrum of this disease, from clinical presentation, diagnosis, response to treatment, and overall survival. So I just wanted to talk a little bit about more of the epidemiology of this disease. So there's an incidence of about 7 cases to a million person years. So it's not that common. It only comprises about 4% of all non-Hodgkin lymphomas. And at the time of diagnosis, the median age of most patients is about 55 to 60 years of age, and there's a male predominance of 2 to 1. Unfortunately, CTCL does have a disproportionate effect on race. So Black race is significantly associated with higher incidence rates and overall poorer survival of mycosis fungoides, and these patients tend to present at a younger age. And these findings were even recently validated in some recent clinical trials. In the 2021 subgroup analysis of Black patients, in the Maverick trial, they noticed that Black patients within this cohort or within their particular study had a survival, the Maverick trial. So it's an international open label randomized trial looking at late stage patients, comparing them to Mogamolism to vorinostat. Here, the authors reported that the clinical characteristics and therapeutic outcomes of the patients within had significant findings for age. So they usually had a younger age when they were enrolled. They had increased frequency of mycosis fungoides as compared to Sézary syndrome, and they had a higher rate of earlier stage disease. The factors that affect survival in African-American patients, though, are really not clear. And so some of our studies are a little bit contradicting. In 2017, there was a retrospective study that looked at the US National Cancer Database and found that there were racial disparities in mycosis fungoides. Those patients tend to have poorer survival than white patients, even after they accounted for social economic factors, disease characteristics, and types of treatment. And in a follow-up study from Memorial Sloan Kettering, they also found that their patient population had inferior outcomes than African-American populations. And that was associated with clinical characteristics. So their study actually showed that there's more of a difference in biology and less of environment. The summation of all of this is really to say that this disease does affect our patient populations in very different ways. So we know that it's affecting our patients differently, that the biology is different by race and gender. Here at Hopkins, we had a question about whether or not comorbidities affected our patient population. So we looked a little bit at our patient population here. So we know CTCL is a chronic disease. We know other chronic diseases such as psoriasis, rosacea, lichen planus also have increased comorbidities such as cardiovascular disease. And so we asked a very simple question, do our patients show higher rates of cardiovascular disease, our patients with cutaneous T-cell lymphoma? Now, we looked around the literature, there's very little out there. Most of the studies that were done are outside of the United States. And so doing a retrospective chart study, a review of our patient population, here's some of our statistics, our background methods, and how we defined our cardiovascular events. We defined our cardiovascular events and our risk factors as above using the American Heart Association guidelines to define these factors. And in our cohort, we found that there were a significant amount of patients in our mycosis fungoides population who were not smokers and did not have diabetes, as well as majority of our patients also didn't have as high of hypertension as our control population. And by our control population, looking at our univariate analysis, we noticed that there was a significant difference in the age of our patients. So they were slightly older, which tends to make sense understanding the disease itself, and majority of them had hypertension. And then looking at our multivariate analysis, we found that there were that our patients here in our control population in our Hopkins control, only age and hypertension were predictive of cardiovascular disease as compared to our control population. So our study conclusions just show that there was a prevalence of cardiovascular disease in our cohort that was similar to our matched control, and that other risk factors such as CTCL, race, gender didn't affect our cardiovascular disease, and neither did treatments such as bexarotene or ECP. And that inside of our cardiovascular population, really hypertension and age were the greatest risk factors. And so really more study will have to be conducted in order to understand the inflammatory state of CTCL and how it affects our other disease states. So what have I told you so far? I've told you basically that there are a few early stage diagnostic markers and treatment options for advanced stage CTCL patients. I've also told you that there are disparities that exist within the CTCL population. And then I've also told you that CTCL biology appears to affect the body differently than other chronic inflammatory diseases. So these points taken together highlight the high complexity and heterogeneity of this disease and really have to be considered within the context of what we know about the pathogenesis of the disease, and better to best direct our research of the gaps in our knowledge. Now, while we don't know the exact details of the mechanisms of pathobiology, we do know that the disease generally includes malignant T-cell development, which occurs due to some aberrant activation of T-cells. So we think maybe some external risk factors such as bacteria, viruses, some type of environmental exposure, maybe even geography or occupational may trigger the development of these T-cells. Then this causes the skin homing T-cells to be generated in the skin lymph nodes, and then those actually have the ability to home, tether, and then migrate into the tissues, usually through these dermal postcapillary venules, as you see here. And then in early stage disease, early stage mycosis fungoides is really characterized by few malignant T cells and really an overall Th1 dominant microenvironment. Whereas in that later stage, you start to see an increase of the malignant T cells and a shift to a Th2 phenotype. Now, we're not really sure exactly what happens between that shift from Th1 to Th2. There's some thought that there's some complex interactions between through the fibroblasts, the keratinocytes, the macrophages, and the malignant T cells, all kind of playing together to change the actual immune system, immune response. And we also are starting to realize that there is a role for gene expression in genetics in this disease as well. So given this complexity and given the heterogeneous nature that we've learned, one of the newer techniques that we're starting to use, which is single-cell sequencing, gives us an opportunity to really evaluate the heterogeneity of this particular disease. So this is an innovative technique used to dissect those heterogeneous cell populations. Whereas when we use bulk sequencing, we may actually mask the subpopulation contributions to overall findings. Using single cell technologies, we can really look at each and every cell within a sample and be able to tell its contribution to the disease. So just a short overview of what that disease or what that technology looks like. We actually take the sample, we're able to dissociate the tissue, isolate them into droplets with enzymes and unique barcodes, and then we can sequence each individual cell. And from that, using computational analysis, we are able to create a unique barcode and cluster the cells into population, identifying subtypes and submarkers within the population. And this already has been used, this technique has already been used to help us understand the disease right now. So we do know that there are more heterogeneity within the malignant T cells. So even though we see a dominant clone, the lymphoma cells are still not quite the same. So there's much still to be learned, and single cell sequencing is one way we'll be able to answer some more of those questions. So in conclusion, CTCL has a heterogeneous complex disease. It has a wide spectrum of clinical presentation, prognosis, and survival. We know their racial and there's gender differences within the population, so we have to keep that in mind when we are caring for these particular patients. And then further understanding of the pathogenesis of this disease really requires more specific analytical techniques that may provide some insight when it comes to personalized treatment options. Thank you.
Thank you so much, Dr. Johnson. And sorry, I didn't get to introduce you. I was going to just briefly introduce that Dr. Johnson is a graduate of the Warren Alpert Medical School of Brown University, where she graduated in 2017. And she performed her residency in dermatology at Johns Hopkins University School of Medicine and completed that in 2021. And now she is on the faculty at JHMI and is an expert in treating patients with cutaneous T-cell lymphoma. So thank you so much, Dr. Johnson. We've already had some questions come in, but I will like to hold off until after Dr. Querfeld has a chance to give her presentation, and then we'll have the Q&A at the end. So Dr. Querfeld, could you please try to screen share, and I'll do your introduction. So.
Can everyone see the screen?
Yes. All right, here, I'll give your intro very briefly and then I'll let you go. So Dr. Querfeld is a board certified dermatologist and dermatopathologist who specializes in the diagnosis and treatment of CTCL. She's a professor and the director of the Cutaneous Lymphoma program at the City of Hope Comprehensive Cancer Center. And she divides her time between her clinic, her derm path practice, and her research laboratory. And she'll speak a little bit about her research today. So thank you, Dr. Querfeld.
Yeah, thank you. And I'm very excited to present today. So I'm going over to some, filling in some gaps. I think it was an excellent presentation of Dr. Johnson. So now I'm focusing a little bit more about emerging treatments and some of the translational work we have done. So these are my disclosures. And so really, I don't want to go, I've already seen the classification, but the treatments is really mainly really for mycosis fungoides and Sézary syndrome. The other ones are so rare that there haven't been really trials and any specific treatments developed. So when we look actually why, and to understand these new treatments, so we have really I think evolved in understanding the microenvironment of mycosis fungoides and Sézary syndrome. So we know that there are three different malignant T cell populations or phenotypes: Treg phenotype, Th1, and then Th17 cell phenotypes. Mostly the Th2-driven immunosuppressive properties have, however, identified, we know, secretion of interleukin 4, 5, 6, and mostly 10. Importantly, 10 are very immunosuppressive. We also know that those MF and Sézary may stem from maybe different cell subtypes, although it's not clear cut, but essentially consider that MF may be a skin resident effector memory T cell, while Sézary stems from a central memory T cell. And it's relevant because they both express CCR4, but their skin residents do not have expression in general of CCR7, while the central memory T cell type of in Sézary is positive. They have, we and others have identified an exhausted or dysregulated immune phenotype. They express exhaustion or checkpoint receptors, mostly PD-1, CTLA-4, LAG-3, TIM-3, among others. They're more actually identified. And we also know that other immune cells in the microenvironment can foster those tumor cells, particularly macrophages and mast cells. And there are increased numbers of macrophages with increasing tumor burden. So we also know there are specific microRNA signatures, and there are also specific pathways and high somatic copy number variations in those tumor cells, particularly STAT pathways, NF-kappa B, TCR signaling. So when we have that, so we have the clinical features. When you assess a patient for management, we have clinical features, we have malignant cells, but we also have the microenvironment. And then does this tie in really into a prognostication? How can we have a management plan for those patients? So precision medicine is on the horizon, but we haven't really fully implemented that because it's a rare disease and we need really large data to prove that. But we're trying this actually on I think every center tries this on their patients. And so what we know, and this is a paper which I really like to always to show, because it's very, very important, not that we need to know all the details about those treatments, but these are all chemotherapy-based treatments. So the results show that there's no long-lasting responses achieved with those chemotherapy, and patients subsequently really need another treatment option. In contrast, actually, when you compare, certain immune therapies which we have had developed at that time, so interferon, for example, has the longest actually response rate, followed, by HDAC inhibitors, and then bexarotene, which as well as transplant here and photophoresis. So when you compare it, the chemotherapy 10 months versus 40 months, it's a big difference. Ideally, we like to get patients, however, cured, which is not possible as of yet. So this is how we understand a microenvironment. We have really the tumor cells. We still don't know after so many years what's really causing the CTCL. So we think it's a chronic stimulation. Whether this is the microbiome or some other sorts, we don't know yet. And so we have the immunologic microenvironment. We have the innate Langerhans cells, dendritic cells, macrophages, NK cells. And then we have escape mechanisms by the tumor cells. Again, the checkpoints can be upregulated. They have also defective apoptosis. So they apoptosis receptors are downregulated, and they actually also secrete immunosuppressive cytokines. And then we have the adaptive immune response, which we want, particularly we want cytotoxic T cells, we want a Th1, milieu. The T regulatory T cells is a double-edged sword, still not completely elucidated how they play a role in CTCL. So these are systemic, and I mainly really go by systemic therapies that have been approved. And the youngest member is really Mogamolism, which when you look at here, at least from the systemic therapies, except probably for the anti-CD30 Printoxima, none of them has really also shown long, huge, overall response rates. It's around 30–40%. And I think this is likely because we also have to, stratify patients critically. And so even this is approved. So this is Printoxima. We show that it's really not, this is a treatment that's usually tend to be given more for tumor patients of MF, or for patients who with Sézary who have actually responded and suddenly develop also tumors. Initially has a very high response rates, but the relapses are very high too. And what we have to really also identify or know is that the this treatment causes significant peripheral neuropathy, so patients really suffer from that. But it's an effective treatment for tumor debulking. And was approved basically in based on a randomized trial when methotrexate was compared, or when bexarotene was when Printoxima was compared to physician's choice, which was either methotrexate or bexarotene. So Printoxima was superior. So the CD30 expression didn't matter. We give it now without even checking, and it could be as low as 5%. But usually at least 10% was deemed to be, optimal for treatment responses, particularly patients with large cell transformation. And I want to point out this is compare overall survival. Those patients don't have really a good treatment. And so Printoxima may be an option for those patients, at least to get them stabilized. These are patients here. You see large tumors, they're frequently ulcerate, develop often, in a pre-existing disease. Often, I think we see this more commonly actually in African-American patients, and as Dr. Johnson pointed out, those have maybe a more aggressive disease. The biology we still have to identify, but just as a treatment option. Mogamolism has been recently approved, and it's a very interesting drug. It actually really targets the CCR4, which is expressed in those malignant cells, that presumably Th2 phenotypes and Tregs. So CCR4 binds to chemokine ligands 22 and 17. They're on histiocytes, which is dendritic cells, macrophages. So we do have, and this was approved based on the Maverick trial, and this was compared to Verino study, randomized trial, which showed superiority actually for Mogamolism. And there have been really almost 200 patients enrolled in each arm. So it's a huge study. So what I want to point out here, so this is patients, particularly the iridodermic patients, Sézary and iridodermic mycosis fungoides respond to that. So what has been really underappreciated was that patients have developed a rash in those patients. These are some of our patients, can be phototoxic reaction, can be psoriasiform, can be even MF-like that you see here. So you have to have a biopsy which identifies really or with immune histochemistry and T cell receptor rearrangement to really clearly be sure that it's not disease versus rash. So it's deemed this because the rash, that Tregs get depleted too, because they also express CCR4. And this is an initial data from Dr. Duvig's group at MD Anderson, who looked into blood component in those patients treated. So more recently, there was a very good paper from the French group in Blood published in this March in 2022, which they felt like what they found is that the overexpression of CCL9 and 11 on macrophages was observed in patients with skin rashes. And you can also see the baseline, the increased numbers of macrophages in rashes compared to baseline. And this may be something that can be treated. We analyzed, for example, patients who were treated with Mogamolism. These are the morphologies you can find, and again, CTCL-like, more like a maculopapular eruption, or more lichenoid and photo, sensitivity reaction. You do see, when you look at pathology, you do see all these bizarre configured cells, presumably histiocytes. And you have to really apply immunostains and TCR to really fully be sure that this is a rash versus CTCL. We know that patients who have rash respond better and have better outcomes. So your rash usually starts in the second to third months in patients, in responding patients. So and skip that. So how do we treat MAR? And basically it's essentially to toxicity guidelines, and we usually, this is a recommendation, we can do if it's less than 10% of the body, topical steroids would do. If it's between 10 and 30%, consider also adding systemic steroids. We used in selected cases oral methotrexate as well as dupilumab, only to treat the rash for a short time. And then more than 30% definitely needs systemic steroids for treatment. So there have been now investigational trials with mogamulizumab incorporating extracorporeal photophoresis or skin electron beam radiation to see whether the treatment response enhanced or actually avoids the rash. So the trials are ongoing. Stanford, our center is included, and some European centers. So there is a treatment, actually, I want to point out, this will probably be developed for clinical phase 3. It's BNZ, it's an interleukin 2 peptide inhibitor. It's a multi-cytokine inhibitor that targets interleukin 2, 9, and 15, which is actually produced by those malignant cells. And so what it does actually in the patients that you can basically you're blocking the malignant cells, but you're also reducing Tregs in those patient population. You can see here a patient at baseline and at week 6. This treatment is given as a weekly infusion. So this might be down the line a bit tiring for patients to come every week, but it's a new option that will be developed. It's also actually a treatment that's developed for alopecia, just on the side, which has the same cytokine imbalances. So we are moving now to a more interesting part, actually, immune checkpoint blockades. When we know that in advanced stages, you have suppression, and in early stages, you still have a more or less intact immune surveillance. That's why you really need a treatment more for the advanced stages. You still have, a good cytotoxic tumor infiltrating T cells. You have more M1 macrophages versus you have a higher expression of those checkpoints in late stages, as well as M2 immunosuppressive macrophages and lack of CD8 tumor tumor infiltrating cells. And you can see this here on the multiplex, which we do. Those patients here on this is a tumor lesion on the right side here has a strong expression of PD-1 on those presumably malignant CD4 cells, interspersed with PD-ligand-1 expression on those macrophages, and it's very, very small numbers of cells in early stages. So when we look, actually, when you stratify this by immune checkpoint marker status, when you combine, for example, PD-1 and PD-ligand-1, as well as some others, you do see it just by the scores, you see a decreased survival. So it's relevant that you actually target and treat the exhaustion. There's a trial, we participate actually from our center, with other centers, actually anti-PD-ligand-1, which targets the PD-ligand-1 on the infiltrating immune cells, macrophages, in a combination with plus minus lenalidomide, which is thought that the combination targets the checkpoints, but also targets the cytokine imbalance. And revising T-cell exhaustion. So these are the responses. You can, this spider plot shows that patients have very, very long-lasting responses, some of them. But you also see that patients here develop progression, right? Actually, we call it hyperprogression in a way, like patients never responded, but instead treatment-induced progression. And so it's only a small number of patients, but we don't know yet why patients progress, and some others are very, very long-lasting responses. So it's likely that patients will need a combination of several checkpoints. And these are some patients I just like to show. For example, this is a transformed patient with ulcerated plaques and tumors, and then it's cycle 8. So one cycle is 1 month. You can see those responses. You can see also here the responses on patients. So it's quite, these are the patients who achieved long-lasting responses. Now, also interesting treatment is the CD47 and SIRP-alpha. It's the innate immune checkpoint blockades. So tumor cells can express CD47. And so that basically protects them from an immune response, and hence they can grow because by targeting to SIRP-alpha, which is on macrophages, by targeting or by binding is you inhibit phagocytosis. If you inhibit this CD47 SIRP-alpha interaction, you induce phagocytosis. And all these treatments, whether it's a SIRP-alpha inhibitor or CD47 inhibitor, target the synapses. And so this is a trial we did, actually, intralesional patients here with tumors. You can see a folliculotropic transformed case was injected, and you see in week 2, you have a traumatic response. This is also the same, another patient who had the same treatment injecting into those tumor nodules in week 2. So when you inject intratumorally, you get a sustained immediate response. And these are the Kyles, these are the measurements of each patient on individual lesions of several patients. You can also see that you're inducing actually an immune response. You see CD8 infiltrate comes into the skin. This is a matched skin sample. But we do not see actually the same effects when we give it systemically. And so likely it gets absorbed by other, in other organs or by other immune cells, because CD47 is really widely expressed. This is data published by Stanford, pembrolizumab, which is an anti-PD-1 blockade, which also shows similarly here that you can a number of patients has long-lasting responses here over 2 years. You can see here, but there are also patients who develop progression and induced or not really by pembrolizumab. And so what all studies show in those immune checkpoints, however, is also interesting, and I wanted to keep this in mind, that the checkpoint expression, the percentage, doesn't correlate with response. So more data to really or more research needs to be done to identify what really happens, and probably likely analyzing the microenvironment. Allogeneic transplant had been usually the potential curative aspect or treatment in CTCL, but it's now a switch that the CAR T cells are developed, and we know this, they are developed already for aggressive B-cell lymphoproliferative disorders. But for T cells, there have been a few studies out. One is basically CD70, interleukin 13, CCR4, CD5, and CD30. So what you do is basically collecting, patients' immune cells, and you can do patients' immune cells, or you get or from allogeneic samples, and to modify them with engineer them to produce receptors on their surface that target basically those tumor cells, and they're called CAR, or chimeric antigen receptors. So and in an effort to really avoid or to overcome the problems we have with allogeneic transplants, that you see a morbidity and mortality of about 30%, so it's quite high. So none of those treatments have, as the treatments respond, but we have, I think the problem is with those CAR T cell therapies, these are essentially T cells as well, and they eventually develop exhaustion. So now our treatments develop who combining CAR T cell therapies with other biologic or immune therapies to overcome that. So in conclusion, so there's still an unmet medical need for patients whose disease don't respond to current treatment regimens. That's why we still need to improve. We probably need to better strategize and stratify patients. The microenvironment really plays a profound role. The immune therapies hold great promise. We just have to learn more and study them in the laboratory to really identify, or to understand what the effects are, not only on the tumor cells, but also on the other immune cells. And we need to identify predictive biomarkers. And I think that's, artificial intelligence, computational biologists who can look into, patients who have, what are the markers who patients have long-lasting responses, and what are the markers of patients who do not respond at all. So I think that's very, very important to understand. And then combinatorial regimens, may improve outcomes. And with that, I'm ending my presentation. Thank you.
Awesome. Thank you so much. So we have some questions coming in from the audience. I think everyone's very engaged. The first question actually was by illary. I apologize if I'm saying your name incorrectly. And it was during Dr. Johnson's talk, but I'd love to also hear Dr. Querfeld's input. They ask, one of the most challenging issues in making a diagnosis is the low detection in histopathology slides and tumor clonality in early disease. How do you go about your cases with a high clinical suspicion that's not backed by labs?
Yeah, so I think that's an excellent question, and one I think we run into quite often, actually. So I am much younger in the field here, but in my experience so far, I think our consensus is if we suspect CTCL, we treat for CTCL. A lot of the mimickers of the disease, psoriasis, eczema, these can all be treated with similar treatments. So quick follow-up, doing multiple biopsies obviously is the way to go. Anything new, the patient knows to contact us, and we're quick to clinically assess them to make sure it hasn't progressed or changed.
Yeah, I agree with Dr. Johnson, with Courtney. The clinician have it's a clinical aspect of it, and because there are really a number of patients where we can't prove it, but it's the presentation, it's long-standing disease, possibly, you know, it's not something that came up 2 weeks ago or 4 weeks ago. It's just long, you know, patients have it for a while, and it's a typical, you know, area. Sometimes you can you know, like the flanks, the buttock area. So this is, you know, all ties in. So it's basically, we call it from the clinical side, we call it, it's MF, or, and even if you think it could be a precursor, we treat the same way because it's skin directed initially.
Thank you.
And sometimes I blame the molecular pathologist, and I said, you know, it's, we switched recently from PCR. I don't know, Courtney, what you're doing. We switched from PCR to NGS to sequencing. And I felt like then when it's negative, then I say, maybe PCR was better. But I I don't know. What's your experience?
We're still PCR here.
Yeah.
I'm waiting for the transition. So
yeah, it's still a challenge. I mean, I think microdissecting lesions where they're doing it, but I mean, you can't really microdissect cells, you know.
Yeah.
So a bit challenging.
Definitely. So the next few questions are all about the treatments that you both mentioned. The first question, the attendee says, thank you so much. Why does Printoximab cause peripheral neuropathy?
I think it's a good question. It's not entirely known. They would think that CD30 expression could be actually, or this is some data who looked into that, and maybe CD30 expression in those nerves or neurons. I'm not 100% sure because I never see really CD30 expression on immune histochemistry. So it may be a bystander effect by the direct chemo that's linked to CD30. That's what I'm thinking. You know.
We had a follow-up response from Univariate. They say, thank you for the response about trusting clinical decision in treating as you can. The only issue is patients sometimes don't want to accept the label of cancer if the labs are non-committal. At least that's what they see in their practice in Lagos, Nigeria. So I don't know if you have any advice for, you know, how to deal with a patient who's having like a difficult time accepting a cancer diagnosis.
Yeah, it's a very excellent, this is an excellent question. I have, we actually want to implement a study where we actually question every patient now at the beginning, whether they understand that their disease is cancer. And some patients don't understand. So we usually counsel, and I counsel that this is from the clinical perspective, we think, so we're pretty confident. We have to underline, you know, repeated biopsies to really, you know, nail it. But we would, luckily, you know, skin-directed regimens are always, you know, the first line, and go from there. So we can, you know, it's also how would I say, it's a patient clinician relationship that develops over time. So they have to trust you and they have to trust your opinion. I don't know, Courtney, what do you think?
yeah, I know, I totally agree with you on that. The relationship is the key part. I know clinic is hectic to say the least, but when I have a new CTCL patient or a new suspicion of CTCL, we have a long conversation about what the disease is and what they can expect with the disease. And I think from there, our subsequent follow-up visits are usually a little bit easier when it comes to introducing new therapies or new topicals or whatnot.
Mm-hmm. Yeah.
Thank you both. Another attendee was asking about pembrolizumab. So the diverse responses to pembrolizumab, some patients have disease progression, others have a long-lasting response. Could this be due to different pathogenesis, different disease phenotypes, or other factors? I don't know if you could speculate.
Yes, it's actually true. It's actually all of them. You have to factor in tumor intrinsic changes, and this can prompt actually certain cytokine milieux can prompt certain immune cell microenvironments. And and I think there are efforts from those centers who have done those studies to look into that and to understand. It's unfortunately CTCL is very heterogeneous, but and so it's probably single cell, as Dr. Johnson pointed out, single cell analysis will help. Spatial transcriptome helps. We're doing this from our end as well to identify that, which is, very, it's not an easy track. It's more like also you need a computational biologist or someone who is doing this on a regular basis to identify this and connect. It is also to understand off-target effects. So once you downregulate something on the tumor with that, something can actually negatively impact it and can be upregulated. And PD-1, for example, we thought initially was only tumor cells, but PD-1 can also be expressed on immune cells, on macrophages. And then likewise, so PD-ligand 1, for example, is mainly really on macrophages, can be, however, induced in any cells, in T cells. So while you have an effect on the target cells, you may have, an effect on the non-target cells and have to deal with it. So it's a very good question. It will probably over time, we will get to know learn this better. And I think critically, we have to analyze those patients with the long-lasting responses and those patients who progress right away, because this is these are the ones, and the ones in between, yeah. So can be then stratified, so to speak. Yeah, very good question. I think it's a lot of things to do still. Yeah.
We had a question from Dr. Ramon Almela. As JAK-STAT signaling is involved, could JAK inhibitors offer an interesting treatment option? Any thoughts about using them for CTCLs?
Yeah, we could potentially. I think there are some actually efforts. Now there's a trial actually, but it's mainly for more cytotoxic T-cell lymphomas. It's used in combination. It's a potential. When I talked to my hematologist, she said, yeah, we could use it, but nobody has really done treating it. I think it's definitely worthwhile. There is, I think, a STAT3 inhibitor or degrader in development. So this could potentially launch, but there's not yet any clinical data. It's a good question. Maybe also a topical. I think I heard there were some efforts in developing or using this, but I think we don't have data that supports it yet. Yeah, so.
Everyone says thank you. We also have a question from Dr. Gulsum Yildiz Alte. She asks about relapse. Do the TRMs play a role in relapse, resident memory T cells?
Relapse. Yeah, potentially. I do not have, however, that's not I haven't looked into that. I only know they're there. And when you analyze a phenotype, relapse is a very complex field. Same with minimal residual disease to look for those, that ties in. So it's not I think we will probably, I think there are groups who are studying this. I don't have more data on that. I do think, yes, they are important. Yes. Courtney, do you maybe you because you do single cell, maybe you have something interesting to say? Yeah.
I wish I had more interesting things to say. We're in the weeds. We're definitely making our way through. I hope we do understand a little bit better about those resident memory T cells and the other T cell populations.
Yeah. It's fascinating. Yeah.
It's a good question.
And we had a question from one of our organizers, Kelly Kimball. She asks, given that patients with large plaque psoriasis are at an increased risk for MF, how frequently should they be followed in clinic for disease progression?
I think that's pretty similar to the one we were talking about with the first question. If you have a suspicion, and as long as you have the conversation with the patient, they understand their risk and what they should be looking for, and that they know they can always reach out if something changes. Same with large plaque psoriasis as well too. If something changes, take biopsies. Take lots of biopsies. So.
Yeah, we love biopsies. Still, I feel I just want to. I'm also a dermatopathologist and said, oh, let me do a biopsy. But then when I'm on the biopsy, I cannot answer the question either from the dermat side. So it's kind of, it's difficult still. I tend to treat patients, with large plaque psoriasis, I treat them the same way like early stage MF. So they're for me in the same risk group. I think there was only really one study which had this number of patients who shown that, but there are no follow-up studies who look into that. Maybe something this can be done. I think there's lots of interesting things to do.
Well, Univariate followed up and said that they're still using mostly methotrexate with PUVA. Very few patients can afford Printoxima, but they'll keep pushing on. So something that we always, are cognizant of with our global dermatox family. It's like what's available for standard of care in different regions. So
yeah, it's important actually. But you know what? My first line treatments. Standard of care treatments when patients need systemic treatments is really methotrexate or interferon. Now interferon will the interferon alpha the regular will be discontinued, I think in 25 or so. But we're using the pegylated now, so that's available for patients. I like patients, sometimes they opt more for methotrexate because it's an easy drug. They can take it, orally and don't need to do anything. Just follow up with labs. And I agree with that because, of course, I didn't mention really the costs, but down the line, probably treatments will become more cost effective. Methotrexate is still broadly available and affordable. Yeah. I like narrowband UVB a lot in combination with systemic. So with PUVA, sometimes if it's very thick lesions, yes, then I do it. But mainly, so it's easier for the patients. That's my take on it. Yeah, I don't know. Courtney, do you do the same? Or
yeah, I usually start off with narrowband UVB. Obviously topicals. Bexarotene is one I use a lot here, or methotrexate. Those are my two go. We are doing interferon gamma here as well too, because we can't find interferon alpha. So yeah, I think it's similar.
Awesome. Well, we're a little past the hour, so I want to be respectful of your time, but thank you both very, very much for doing this special panel on CTCL to kind of round out the year for us. This is our last seminar of the year. We're very appreciative, and as you can tell, the audience was asking a ton of questions, so they're very interested in your work. And we're getting so many thank yous coming through. Another thank you just came through. So we appreciate everything, and we look forward to seeing everybody in the new year. Happy holidays, everybody.
Absolutely.
Happy
Take care.
holidays. Thank you. Exciting
holidays.
session. Bye.